This 38-year-old Haitian computer programmer has been known to be HIV positive since 1991, when he presented with a CD4 count of 276 and new-onset dyspnea secondary to bronchiectasis. Since then, he has received the full spectrum of HIV therapy, which he has taken with variable compliance. His disease-related complications have included shingles, chronic sinusitis, depression, and oral candidiasis. 2 months prior to this exam, he presented with high-volume diarrhea, which on stool analysis revealed cryptosporidiosis. He was begun on paramycin, azithromycin, and Imodium, which eventually controlled his symptoms. He also restarted his antiretroviral therapy to gain more definitive control of the cryptosporidiosis. This exam was performed to evaluate the success of therapy. On upper endoscopy, the duodenum is markedly abnormal, with edema and nodularity of the mucosal surface. The fine endoscopic resolution seen here permits visualization of edematous villi. The terminal ileum seen at colonoscopy had a very similar appearance. The patient's CD4 count at the time of this endoscopy was 45, with a viral load of 114,000 copies per mil. Biopsies were taken, revealing mucosal injury with villus flattening, regenerative epithelial changes, and lamina propria inflammation. Higher power shows that the surface epithelium is lined by small round organisms measuring 2 to 4 millimeters. The appearance is characteristic of cryptosporidiosis. Most human cryptosporidial infections are caused by the species Cryptosporidium parvum, which invades and spends their life cycle in the intestinal epithelium. Diagnosis is made by the finding of the oocysts excreted in the stool using a modified acid-fast stain or by ELISA or direct fluorescence antibody tests of the stool. Antiprotozoal therapy usually fails to clear the organism in the setting of low CD4 counts. Thus, the main focus of therapy is the institution of aggressive antiretroviral therapy.